in lab today. It will be four pretend people. And so we don't know what their blood type is. All right? We'll say they only have one red blood cell. And we don't know what antibodies they have. Okay? So that's the unknown. We don't know the antibodies and we don't know the antigen. Which one is going to be the easiest way to figure out their blood type? Find the antigen or to find the antibodies?
Antigen.
So that's the antigen, because we have A and B antigens and no D antigen. We know their blood type is AB negative, right? Whereas with antibodies, remember, we weren't sure. They didn't have D antibodies. They could be either negative or positive, but we're not sure. So it's easiest is to find the antigen. Okay. So if this person, let's now say that we do know what's going on. This is what we're going to do today. So let's say that we do know what's going on. And this person has a B antigen on their blood, okay? And they have a D antigen on their blood cell.
Positive.
So what's their blood type?
A positive.
No, B antigen.
Antigen. Oh, B positive.
D,
Oh, B positive.
B positive, okay? So their blood type is going to be B positive. Let's do it another way. Might be redundant, but just,
Practice makes perfect.
yes. At least better. All right, this person has no antigens on their blood.
Negative.
Which one?
Oh, negative.
O negative. A, B, and D.
AB positive.
Okay, AB positive. So by knowing the antigen, we know the blood type.
Yes.
Okay? So in lab today, to be consistent, we're going to take a sample of blood and we're going to put it, let's see if I can do it in the right order here. You're going to get 4 trays because we have 4 individuals. They were all in an accident and we need to transfuse them and we don't want to give the wrong blood type. All right. So your tray will look like this. And you will be given a file of 4 people, Brown and Green and Smith and Jones. So you're going to have to do a separate tray for each of them, right? And so let's say that this is Brown. And we take some of Brown's blood and we put it in here. Notice I don't care what the antibodies are. I'm looking for antigens. Okay? And so I have 3 vials here. And one vial says anti-B, antibody B serum. Remember that's plasma without other antibodies in it. So how can we have antibody B serum? Does the serum mean no antibodies?
Serum means no clotting agent.
Serum means no clotting agents. So meaning fibrin threads aren't going to be formed. Agglutination can occur, coagulation cannot. All right? Agglutination is the antibodies clumping things together. Coagulation is fibrinogen to fibrin. So I'm going to take a drop of anti-RH, or a couple drops, and I'm going to mix it with this. So this is antibody against the D antigen. It's not antibody that's in the blood, it's antibody that I've added to the blood. That's critical here. That's where students have the most stumbling blocks. All right, so this is antibodies that I have added to the blood. And then the blue is antibodies against A. Antibodies to the A antigen. Okay, this is antibodies to the Rh antigen. And I don't have yellow, so I'll use red. And this is antibodies to the B antigen. Same blood though, all right? But I don't know what antigen is on that blood. So what's going to happen, actually let me change this to 2 red blood cells, because that will help my illustration work a bit better. So what will happen if there is an A antigen? Will it will agglutinate. So if I have, again, I'm not concerned about what antibodies are in the blood, but if I have A antigen on my red blood cell, this will cause it to agglutinate. Okay? And let's say that I don't have D antigens on my red blood cell. So no agglutination will occur. And I do have B antibodies, B antigens on my cells. So the B antibody will find those B antigens and agglutinate my red blood cells. Everybody follow that? So it's like I'm fishing for antigens. I'm using antibodies at the end of my fishing line to see if they find any antigens on the surface of the blood cells. So if, given that result, this is A, this is B, and this is Rh, I see agglutination with the A antigen. Now you'll see this on the slides, it will start to clump. You can look, if you want to look in the microscope under 3x or 10x, you can also see it in the microscope. By tilting it back and forth over a piece of white paper, you should be able to tell whether it agglutinates or not. We didn't have a D antigen, so that will not agglutinate. We did have the B antigen, so the antibody is going to agglutinate those red blood cells. Therefore, what's my blood type?
O negative?
Not O, I have A antigen. I have B antigen. So I have A, I have B, I don't have Rh, so it's negative. Okay? Now, let's take a look at this one here. What would you expect this one to look like?
All of them are there.
Okay? I would have agglutination for A, I have agglutination for B, and I would have agglutination for D. Okay? O negative,
Nothing.
Nothing.
nothing would agglutinate, because I wouldn't have any antigens. Okay? So, one last thing before you try this out. I show you on your quiz slide today, and I will tell you which ones have agglutinated. Okay? So let's say that we have something like this, and I'll put a legend over here, and this means no agglutination, and this means there is agglutination. Okay? So what's the blood type?
B negative.
B negative. Okay, I'll leave that up on the board. Divide yourselves into your lab groups again. Each lab group gets 4 of these trays. So you'll want to get a blank piece of white paper, maybe put the name by each individual. Assign one person to put the blood in the trays. Maybe assign another person to do the various antibodies, divide it up so that you're not overlapping. One person tests one individual, do everything for that one individual, however you want to divide it up, so that you keep straight who's who and what the antibodies have been added. So you'll want a box of trays, you'll want the individuals, you'll want these antes, and then you want toothpicks. And you'll want to stir each toothpick with, each blood with a different toothpick, all right? So you can either use all the same colors, or you can use a different color. It's probably easier just to grab a bunch and stir them, and then you can throw them away. So for each test that you do, however you figure it out. So just go ahead and come up here and, actually, I think they have this up. So just take a whole test tube of toothpicks, and then just make sure you don't use the same toothpick. So there's a set there. And then when you're done, just rinse and dry the trays and bring them back up.
Let me see if I can take one of her scrap papers.
What's that?
Having dinner.
You can do it. I figured you were gonna do it first.
Yes, we're doing the very,
I just wanted
we're
to
doing
buy
that
one
with the
person.
lab.
Oh, okay.
Did you do the blood test?
Yeah,
That's what I did too. So don't, I was like, okay. Did you The more the merrier. I did that, and then I was looking for this too, Amy. I was looking for this on video, and I was like, where the heck is this? And I was like, oh, it's in the book.
I could have slept
Did you
in
turn your
one.
lab in? No. Okay, cool.
Miss Brown, we're gonna get her blood.
We got Miss Brown. We got.
So each one of the little vials is different.
Yes.
Yep.
Of course, Mr. Smith. Male and female. And Mr. Graham. I only have one girl. Oh no, Mr.
I killed it.
Tell me one of you have Mr. Anderson.
Who did it?
Mr. Smith
Damn it.
and the.
Mr. Smith.
I think it was Mrs. Brown in the RH pack
Ben and Early.
last night.
Your blue. The what there?
I got Mitter Smith.
Her blood.
You have it?
I have Mr. Jones.
Okay, so do we just want to, someone want to start pouring some of them?
No, that's Mrs. Jones. You were
Awesome.
Okay, so this is Mr. Smith. Everybody write it down.
I wasn't paying attention either.
Well, for the unknown, we put Mr. Smith.
Yeah.
So Mr. Smith.
Are we not going away?
Probably could.
Those you may throw.
I think she has the antibiotics.
Plastic, but we have the actual
So
antibiotics.
that's when we get the different color toothpicks instead of all the same.
Yeah, sure. Okay, Mr. Brown.
I don't want to get confused.
Do you want anti-A or anti-B?
Just give me one more question. Anti-B.
What should we use? Okay, so blue, or blue, green, maybe three, whatever. What's the green one?
Do you want to make, you can make okay.
So if we use these ones for the same one over, can we reuse it?
Oh, it's Miss Brown. Oops.
Is she mistaken her?
No,
She actually
she is not married.
She's Miss, so she got divorced. I think. And then she's MS.
Mr. Jones.
Can we get toothpicks, guys?
Can you
Sorry about
write
that.
Mr. Jones?
You're slacking.
Way to not share.
I did all the beats. Well,
I can't find our lab technician. In case he wants to keep them just.
can we use the yellow for all the ones we mix with anti-basic?
Yeah.
It's changing color. Maybe I should do this so you can actually see.
The green?
Just in case the lab tech wants to see.
Well, no, we're gonna, I guess, mix them with all of them.
You don't have to.
You don't have to. Okay.
B?
I think that one agglutinated. So I'm adding the antibodies.
Which one is that?
So if it
If I see your
connects.
I think Mr. Smith might be on negative.
The word is, but it is A, right?
Yeah,
It has A antigens.
I'm trying. Maybe that's.
So that's on, it's gonna go on A, right?
Yep.
It's not the color though, should we get clumping?
The same amount of drops.
And look at, compared to
Do I
mine.
mix it?
Do I put three?
I guess do another one.
So if I have
So
A, B, and D antigens.
I don't think it's clumping
I don't see, so I see no.
So it's not, there's no A.
Yes, but
Yeah, I think he's on negative.
the B
It's like Mr. Jones
and
is
there's
pretty
no
negative.
antibody. So is there antigens? No. Is there B antigens?
is B negative.
Is there
Mr. Smith is O
No,
negative.
so there's no antigens.
Guys, I don't think I'm doing this right.
You're searching for that
It's not clumping.
You're adding the thing you were doing last day. You're
Okay, so
adding
hold on.
antibody and mixing it in
The oxygen?
Yeah. Yeah, you add the antibody.
You see something in there? It looks stringy, right, or something, or?
You add the antibody, mix with the antigen, and then you put the next.
Should I stir it again?
Try it again.
Okay, so, okay, so don't say anything yet, let me guess.
So you're making it harder.
Yeah, because it's fuzzy,
I
right?
have to think the steps.
So maybe it did.
I'm trying to use my steps. So we're testing. These are little features.
Well, when she comes back, we can show you.
You're right. So their blood type would be B negative. Everybody follow that? Now, the key word is the blood contains those antibodies. We didn't add those antibodies, all right? Now, what you did in lab this morning was you added antibodies. Okay, so in this one, the blood sample reacts by agglutination. We showed the little clumping on the fibers with antibodies to A. So when I added the A antibodies, I got agglutination. Okay? When I added D antibodies, I got agglutination. So what does that tell me about the blood type?
Negative.
I have antigen A, and I have antigen D, so my blood type is A positive. So this is the difference between testing for an antigen and my telling you the antibodies are already there. What does that tell you about the blood type? All right, so this is what you did in lab. We added in these antibodies, searching for the antigens. That is significantly different from having the antibodies present and then inferring from that what antigens are they going to be on the blood cells. Okay. So what you did in lab was search for the agglutination. You added the outside antibodies. These were not antibodies already present in the blood. So anytime you see a situation like this, we've added the antibodies to A and found the antigens. We added the antibodies to B and didn't find the B antigen. We added the antibody, or D. We added the antibodies to B and did find the B antigen. So this is what, when we talk about typing and cross-matching, this is typing. So when you do blood typing, you add antibodies of the 3 different antigens, A, B, or D, searching for those antigens. All right? Then we cross-match by mixing actual blood samples from the recipient and the potential donor to see if there's some mistake that was made and they would actually be compatible before we put the blood donation into the recipient. Okay. So again, for the blood typing, anytime you see this kind of pattern, agglutination means antigen is present, you add that to your blood type. The agglutination is absent, the blood type is not going to include that. Okay? So, if my blood type here is A positive, that means I have the A antigen, and I have the D antigen. Would I have antibodies, intrinsic antibodies within the blood?
Yes.
Yes. And what would they be?
B.
B. So I'm going to have B antibodies in the blood. Okay? Now I didn't search for those, but because I know my blood type, I can infer from that that they would be present. All right, let's go a couple of steps further. If this blood type is B negative, to whom can this person donate their blood?
Any negatives?
No.
Not any negative.
They can't do.
They can be negative or positive.
They can't go to A.
All right, so we have A antibodies and we have D antibodies. So it can't go to any positive.
They can't go to A.
So it has A positive, can it go to A?
No.
So are we worried about what antibodies are in this blood?
We're worried
No.
about.
We're worried about the antibodies in the blood we're giving it
Yeah.
to.
And it
Okay,
has-
so can we go to B?
Yes.
Yes.
Go to B negative.
Well, the person that is B negative and I have antibodies against this person?
Huh?
The negative, well, they have antibodies, there's no antigen here, so that
No,
doesn't matter.
Yeah.
And the positive doesn't have antibodies, so that negative is okay. Can we give, so we're fine with our negative positive, okay? Because this is negative. So there's no antigen there to react whether or not there's antibodies. That's why this is okay. We're not adding any antigen to any antibodies. Even if this one had antibodies, because it had an exposure, it wouldn't matter, because there's no antigen, there's no D antigen present. All right, now we're just worried about the B. We can give B to B. Can we give B to A?
No.
No.
A.
AB?
Yes. Because there's no antibody? No.
AB, would AB have any antibodies?
No.
No.
Okay.
So we can give this to AB,
Is it just negative?
positive or negative.
And negative O.
Can we give this person to O?
It
No.
has antibodies.
It would have,
A and B.
O would have antibodies A
And B.
and B, so we can't give it to O. Okay? So this is who we can donate to. Who can we receive from?
Negative receiving.
It's just the same thing, but the reverse. So what antibodies do we have?
We have
A and D. So we cannot receive
A.
A, and we can't receive D. So we can't receive any positives, okay?
Okay.
So we can only receive a negative. We can't receive anything with A.
A antigen.
So, right, can we receive a B?
Yes.
Yes. So we can't receive A, can we receive AB?
No.
No, because it has A.
It has antigen.
So remember, we can't receive anything with A, that knocks out A, that knocks out AB. Can we receive O? Yes.
O negative.
So we can receive O negative,
Anything can receive O negative.
okay? Now let's do this one. So A positive, we can donate to anybody that doesn't have A antibodies and doesn't have the possibility of having C antibodies.
Any negative.
Okay, so we
Most
can't
negatives.
donate to any negative.
Most negatives.
Well, we don't know.
Because we don't want to give it to them.
A negative may or may not have a positive, and we have no idea. And if they don't have an antibody, we don't want to develop antibodies. So we can only give positive to positive, always and forever. Okay?
Not all blood types though.
It's not all blood types, but whatever blood type we give, it can only be positive. It can never give to negative. Positive can never be given to negative, no matter what the other part is. All right? We have antibodies to
B.
B.
So you can't do any B's, but you can go A positive.
So we can give to A positive.
You can't do
Um,
any B's.
We can't give to B. Can we give to AB? Yes, because AB has no antibodies, so it's not going to have antibodies against A. But it can only be AB positive. Okay? So who can we receive from?
A positive.
positive or negative, does it matter?
No, because it already has it.
So we can receive positive or negative, because it has the positive.
It already has
We
it.
can definitely receive the A. Now, can we receive B? No, because we have antibodies against B.
So we'll eat it.
So we can't receive AB because we still have antibodies against B. Can we receive O?
Yes, because
Yes, because O has no antigen, so we have no antibodies. So we can receive O,
positive and
positive or negative. So the questions you ask are essentially the same questions. The big pool of blood can't have antibodies against the smaller amount coming in. If I'm donating, I can't give to antibodies. If I'm receiving, I can't receive the antigen if I have the antibodies. So you're still looking at the same pattern. All right? Why don't you guys take about a 15-minute break to either get more confused or to go for a run or to study a little bit more. And I want to do the lab quiz before we move on into the other lecture material. So the quiz is going to be identifying three things. It's going to be identifying white blood cells or red blood cells or platelets. Okay? It's going to be identifying the equipment needed to do hematocrit or hemoglobin or sedimentation rate. Those long tubes where we wait for the red blood to settle. It's not going to ask the purpose or the ranges or whatever, just what blood test would be used. And then it's going to ask you to identify blood type based on the agglutination pattern. For the glutenates, it has an antigen. Okay? So based on the far right, based on what you did in lab. So those are the three components on the quiz. And I just want to get that out of the way before we start looking at other things.
I have a question. We know this is the centrifuge. This is not a centrifuge as well, is it?
No, this is a machine that you have a plural model for what we actually use it for. Now a couple of these. So this shows the lymphatic components. All of those white lines are showing the lymphatics, and all the little yellow dots are showing lymph nodes. Right? So remember, as the lymphatic fluid is following the venous pathway, and on the lower extremities, abdomen, pelvis, left side of the chest, left upper extremity, neck, and head, left side of the head, it's going to enter into the thoracic duct. At the base of the duct is a dilation known as the cisterna chyli. And this was the function of the lymphatic system in carrying adipose tissue was found after, I wouldn't say experimental, but stray dogs were used a lot for a long time for practice surgeries by medical students. I first participated in that when I was a graduate student at Loma Linda University for my master's. I had to do some teaching methods, and the medical students would put the dogs under, basically stop the heart, restart it, and then let the dogs die under anesthesia. And these were dogs that they obtained from the pound. They weren't a collection, and so I had a problem with that. It was an optional activity. It was kind of a whole, this would be cool kind of thing. Let's see what, the effect of the drugs and stuff were on the animals. And because it was optional and it was more of a, let's do surgery on dogs kind of an approach, I don't have a problem doing experiments on animals and such, but not when it's just a throwaway experiment like that. If it was part of a required class and they were doing certain techniques that they had to learn later on and they were going to use on humans, yeah, I can see practicing on, and many animals, pigs and dogs are used for practical developing new surgical techniques before we go and do them on humans. But just, here's a cool surgery, let's go cut open a dog and see its heart kind of a thing. I had a problem with that kind of an attitude more on the students. There certainly were things that could be gained from the lab, but not in that kind of environment. But in that type of procedure, when they gave dogs high fatty diets, they found that, not this particular experiment that I was doing, that was something that was more heart and cardiovascular, they found that the lymphatic fluid, bless you, and the cisterna chyli and thoracic duct was very milky, almost a yellow color. And so in processing that, that's how it was discovered that the lymphatics, the lymphatic capillaries in the digestive tract, which we'll talk about in a little bit, are how the lipids get into the bloodstream. Because remember, the lymphatic capillaries, their cells can spread apart. And so lipid droplets that are coated by proteins have easier access to get into the lymphatic capillaries than they do into the blood capillaries. And so the portal system takes the high concentrations of amino acids and sugars to the liver first, but the lipids get into the cisterna chyli, the thoracic duct, and up here into the left, subclavian first, and then to the heart. So you can see the lymph nodes in the axillary region and so on, cisterna chyli, thoracic duct, and right lymphatic duct. And that's an issue what this huge model is good for, is those particular structures. However, let's take a look now at those lymphatic structures, and we start from simple to a little more complex. So the first few slides are showing the cells that are involved in the lymphatic system. Remember, we kind of left this at, well, we started out with the source of the fluid. The reason why we have a lymphatic system is to return excess fluid that has left the capillary system back to the heart. And because that excess fluid is coming from the connective tissue, it can pick up bacteria and viruses. If there's any tumors, it can pick up some stray cancer cells, and we don't want to just dump that back into the blood, which is sterile, or should be sterile. And so we pass it through a series of filtering systems, the lymph nodes, on its way. So those lymph nodes are part of our lymphatic system. But even before it gets to the lymph nodes, it's going to pass by free and diffuse lymphatic cells. So let's take a look at the cells that are involved. And we have the lymphocytes. So we have T lymphocytes. We're going to talk about their function on Thursday. We have a variety of T lymphocytes. We have T killers and T suppressors and T helpers. So we'll look at those on Thursday. Here is a T killer cell with direct contact through receptors and recognition proteins, and it's going to result in the lysis of this tumor cell. It does that with tumor cells, virus cells, transplanted tissue. Then we have the B lymphocytes. In the blood, you can't tell the difference between a B lymphocyte and a T lymphocyte. However, once the B lymphocyte is activated, we have a cell producing antibodies that has gained additional cytoplasm, additional Golgi apparatus in this light staining area, additional ribosomal ER for making proteins, and antibodies are proteins. So B lymphocytes are converted to plasma cells once they become sensitized to an antigen. Macrophages. Those of you that have microbiology, why do we include macrophages in a lymphatic system?
They're antigen-presenting cells?
They're antigen-presenting cells. We'll talk about that procedure on Thursday, but they help to initiate the sensitization. So T cells and B cells have receptors on their surface that one particular B cell would have a receptor on its surface. It's essentially an antibody that recognizes only one antigenic site. And so to activate that B cell, T cells are presented with a variety of antigens, and if they happen to match that up by, say, something that the macrophage has ingested, processed, and put on its surface bound to another protein, and a T helper cell bumps into that and it matches, that activates the T helper cell to release chemicals that activates T killers or plasma cells, B cells to plasma cells. So this is involved, even though it itself doesn't have specific requirements, it will phagocytose anything that is foreign or that doesn't have self-antigens on it. It helps to activate the specific requirements of T cells and B cells.
So when a B cell is activated with antibodies, it becomes a plasma cell
Yes. Not with antibodies, but it's activated to secrete antibodies.
to make antibodies.
It is then a plasma cell. And then we have reticular cells. You guys remember reticular tissue from Bio 430? Reticular fibers. What cell type made reticular fibers when we were looking at connective tissue?
collagen fibers or
It's a type of collagen, but what cell makes them?
fibroblasts?
Fibroblasts. So reticular cells are really fibroblasts that make a specific type of collagen, and then they wrap their cell body around that. So when we see reticular tissue, we're not really seeing the collagen, we're seeing these long, thin fibroblasts that are wrapped around the collagen that they secreted. And they tend to form short branching fibers that form a mesh. And this mesh or network supports high density concentrations of lymphocytes. And so we see reticular fibers in lymphatic tissue, lymph nodes and tonsils and the spleen. It helps to support the concentrations of lymphocytes. All right, so now let's look at the tissues. And we're going to go from not very complicated, all right, to more complex structures. And so we start out with diffuse lymphatic tissue, which is just scattered lymphocytes, to lymphatic follicles, and there should be an extra L in here, to lymphatic follicles, which are highly concentrated lymphocytes, but without a capsule. And then we'll start adding capsules. So we typically find our defense cells immediately deep to epithelia. So in the papillary and reticular layer of skin, in the mucosa of the mouth and respiratory tract and digestive tract. And so they form this MALT, or what's spelling here, mucosa-associated lymphatic tissue. And remember, mucosa is almost all of our epithelia, lining body organs associated with loose, irregular connective tissue. So these are various components. Tonsils have a partial capsule, but the rest of these structures do not. So let's look at an example of diffuse lymphatic tissue. So I'm going to give you characteristics of these different tissues and organs. Questions, lecture type questions on them. Obviously lab questions are just to identify them. Lecture type questions would be of two types. So which of the following lymphatic tissues or organs demonstrates a capsule? Or I might list the characteristics. And the spleen would have 1, 2, and 5 of the following characteristics. Okay, so a table with the characteristics or some kind of association that you can compare and contrast would be helpful. So here we're looking at the small intestine, and to increase surface area for the secretion of enzymes and the absorption of food products, the small intestine has long finger-like villi, and that's what you're seeing here. So these would be simple columnar cells, and these are intestinal glands down here, right? And that's what this model is that we'll look at towards the end. And this green structure right here, these are the blood capillaries picking up amino acids and simple sugars. And this green structure is the lymphatic capillary, picking up absorbed lipids coated with proteins. You can see a little bit, not very clearly, but you can see a little bit of one here, a little bit of one here. And the specific name, you'll have it in your lab list for lymphatic capillary in the digestive tract, is a lacteal. L-A-C-T-E-A-L. Scattered all around that, we have diffuse lymphatic tissue. Also, all these purple dots are lymphocytes, B cells and T cells. Right? They're not organized into any structure. They're just scattered, like you were to take rice and kind of throw it out across the sidewalk after someone that's getting married. It's just kind of a scattering of them. More highly concentrated in certain areas, all right, right under the epithelium here, but not organized into a sphere. Hence the word diffuse. Then we can organize them into follicles or nodules. Now I prefer the term follicle because once we put a capsule around them, it's called a node. And students get mixed up between the node and the nodule. So it's just easier to use the term follicle, and then you're not confused what you're talking about. So on the model of the intestinal tract here is a follicle. It's a high concentration of lymphocytes in a sphere. There's no capsule around it, so it's just reticular tissue holding those lymphocytes and keeping them from diffusing out. They tend to have a higher concentration of T cells in the periphery and B lymphocytes in the center. So you can see that on some of these. Let me switch the image to a higher power here. So here's something similar to what I have on the model. We're in the colon right now. Here is a single lymphatic follicle. It's a little hard for me to see close up, but those of you farther away can see that this area right here appears lighter. And that's because there's more white areas around the nuclei than there are out here. That happens when B lymphocytes are activated to become plasma cells. So if we look back at this slide at a plasma cell, notice how much more cytoplasm it has than a typical inactive lymphocyte. So that's going to make the cell lighter. So when we have inactivated lymphocytes, especially B lymphocytes, like here, there's no light center. Here's a light center, here's a light center. Those are called germinal centers, and they indicate a high population of plasma cells. So one or more antigens have converted B lymphocytes to plasma cells. So again, the center of a follicle contains more B lymphocytes than T, and the T lymphocytes tend to be on the outside. This particular area of high lymphatic follicles is found in the distal ileum. That's the last part of the small intestine before food moves into the large intestine. Is it normal to have E. coli bacteria in the small intestine? No. In the large intestine, yes. Remember, that's where we got our vitamin K. So we have this at that last 3 feet or so of the small intestine in case bacteria from the large intestine migrate upstream into the small intestine and get access into the connective tissue deep to the epithelium. We have this high density of lymphocytes ready to protect the body from invasion by those bacteria. So those are Kayer's patches, specifically that term for a high accumulation of lymphatic follicles in the ileum. All right, so no capsule, lots of reticular fibers with lymphocytes and macrophages, some antigen-presenting cells, the dendritic cells we talked about in Bio 430 with scan are found there as well. And so this provides any kind of pathogen that happens to make its way through here is going to have to percolate, find its way through all of these lymphocytes, and the chances are high that it's going to bump into one that has receptors on its surface that recognize some antigenic component of the virus or bacteria. Either a single or multiple follicles. All right, now we get to lymphatic organs. And these lymphatic organs have a capsule. That's what is common to all of them, at least a partial capsule. So we're going to look at the lymph node first, because that's what all of the lymphatic fluid has to pass through. All right? And then tonsils are specific. They're similar to lymph nodes, but slightly different, that we find in the pharynx area. The spleen is the only lymphatic organ that filters blood. And then the thymus is a special, it's not a filtering organ, it's a nursery, if you will, for T-cell development. So lymph nodes, again, are scattered along the lymphatics. So any lymphatic fluid is picked up by lymphatic capillaries, passes along the lymphatic back towards the heart, but it has to pass through multiple lymph nodes. Most of you have probably experienced a swollen lymph node at one time or the other. If you had a sore throat, you would have swellings along. If you go get your teeth cleaned, they always kind of palpate there to double check the lymph nodes are down the side. You may have one or two in the axillary area. So by region, I think I have regions listed in your lab packet, but it's just, cervical lymph nodes are in the neck, axillary lymph nodes are in the axilla, and so on. So along the upper limb, they tend to follow the veins. Here's a high accumulation in the axillary area. So did I talk about breast cancer? And okay, so we did that on Friday. So if those lymph nodes are removed, it's going to interfere with the lymphatic drainage until additional lymphatics are developed. You can see here on the mammary gland, the tail that I talked about. And so more often than not, breast cancers are found in this area. They can be found in other areas. And so that's why it's very common to have these axillary lymph nodes be affected if there's any primary metastasis. Obviously along the digestive tract, down along the ileum. So here's an image of a lymph node. You have this diagram on page 48 as well. And I'll diagram one. It has a kidney or kidney bean shape. And so we'll draw this in like this. So we have a convex surface and a concave surface. It has a capsule of dense irregular connective tissue. And coming into the convex surface, we have lymphatics coming in from downstream. And these have valves. Remember, lymphatics have valves. So the valves are going to be directed so pressure will open them. So this is coming from other lymphatics and other lymph nodes coming towards the lymph node. So these are identified as afferent, lymphatics. And they empty into spaces just under the capsule. The capsule also extends down towards the center of the lymph node. And these are identified as trabeculae, still dense irregular connective tissue. Kind of like the segments we talked about with the testis, but not as many. And we're going to populate this with lymphocytes, all right? But our lymphatic fluid is going to flow through the lymph node, and then it's going to leave the lymph node through efferent lymphatics. So our valves are going to be in the opposite direction. So they're going to allow this to open out. So these are identified as efferent, going away from. Now if you think about it, this efferent lymphatic is going to flow along to another lymph node and will become the afferent lymphatic at another lymph node. All right, so it's only at the lymph node itself that we describe it as an afferent or efferent. So here's a lymphatic coming into this lymph node. It would become that lymph node's afferent lymphatic. This would be efferent, but it would become that one's afferent. So right at the lymph node itself is where we identify the direction of flow. I guess I'm drawing this backwards from the diagram, but anyway. Now, let's put in our lymphocytes. Okay? So out in the cortex, this area out here that extends to the trabeculae is identified as the cortex, and this center area here is identified as the medulla. And we find one or more lymphatic follicles in the cortex. So again, these are going to be the dense accumulations of lymphocytes, and I'm only going to do a few here. and there will be scattered lymphocytes in other areas. So there's reticular fibers holding these lymphocytes together. And then there are, I'll draw the reticular fibers in black because that's how we see them. But then there would continue to be some reticular fibers out here as well. And we have macrophages out in this area. So the lymphatic fluid comes in and then it can flow, I'll use purple because it's not blood. So it comes in through here and then it can flow under the capsule in a space right here of fibers and scattered lymphocytes and macrophages. And that space is identified as a sub, meaning below, capsular, not scapular, we're not talking about the scapula, subcapsular sinus. Okay, so just under the capsule is a channel that lymphatic fluid can flow. Another option it has is if it's under the it's within the subcapsular sinus, is to flow down on either side of the trabeculae. That's identified as a trabecular sinus. As it flows through these channels, it's going to meet some lymphocytes. It's also going to have the opportunity to come in contact with macrophages, all right, which will phagocytose it and present it. But out in the cortex, there's a significant dense accumulation of lymphocytes that it will eventually, in probability, some of it will percolate through the lymphatic follicle. And it won't go in a straight line. It'll have to move around cells. All right, so the more it does so, the more exposure the contents of that lymphatic fluid get to B cells and T cells and macrophages. Once it passes through the cortex, it enters the medulla. And now our lymphocytes are organized more into columns rather than spheres. And so the easier flow is through the spaces in between the columns, but there will still be some irregularity. We're in the medulla, and so these are called medullary cords, where we have a high density of lymphocytes, and medullary sinuses, where we have just the channels. All right, so again, reticular fibers in the channels and reticular fibers holding the lymphocytes together. So this would be a medullary cord, and the space would be a medullary sinus. So it comes in the afferent lymphatic, goes to either side in the subcapsular sinus, goes down the trabecular sinus or through the lymphatic follicles. These follicles have the same pattern as our unencapsulated follicles. T cells predominant in the periphery and B cells predominant in the center. Then as the fluid percolates through into the medulla, we have the medullary cords, and those are also predominantly T cells. All right, so we find predominantly T cells in the periphery. I'll put that a different color so you can see it. So T cells in the periphery, T cells in the cords, B cells in the center of the lymphatic follicles. So this structure has a capsule. It has follicles. It has lymphatics, both efferent and afferent. and it has the medullary cords and sinuses. It is the only one of all of our lymphatic organs to have afferent lymphatics. Our other organs, like the spleen and the tonsils, will have efferent, but they will not have afferent. They will get their source of fluid or bacteria from a different component. None of our other structures have medullary cords or sinuses. The thymus has a medulla, but it doesn't have medullary cords or sinuses. So the afferent lymphatic, the medullary cords, the medullary sinuses, we only find within the lymph node. Okay? So you can see how with a parasitic infection, that can get trapped in the lymph node and proliferate amongst all these fibers and block lymphatic fluid through this. If you've got worms and stuff growing in there. That
Can you-
was wonderful.
Can you repeat again what's only found in the?
What I showed in red,
Okay.
so the afferent lymphatics, the medullary cords, and medullary sinuses. And it's up here on the screen as well. Go ahead and take a picture if you want to, because we're going to switch to tonsils. How many of you have had any tonsils removed? Okay, remember it? I was 5 when I had my palatine tonsils removed. So I remember being in the gurney going off for the surgery. My aunt was in charge, the surgical charge nurse. And then I remember waking up in my parents' bed and getting ice cream. There are 3 locations of tonsils. All of them are associated with either the nasopharynx or the oropharynx, the mouth itself. And of course, we have a lot of viruses and bacteria coming into our nose from the air we breathe and into our mouth with food and fluids that we ingest. And so these show the location of where we find tonsils. The nasopharyngeal tonsils are also known as the adenoids. So surgery to remove nasopharyngeal tonsils are sometimes called an adenoidectomy. My son had this done when he was about 14 months old. He was having, well, he was born with issues with his palate. And when he talked, they had a hard time deciding whether he had too much air or not enough air. And he did a barium milkshake where he drank this, and then they took a video of him swallowing. And I got to watch his palate move up and down. So here's the palate. That's your hard palate and soft palate, the roof or floor of your mouth. And the nasopharyngeal tonsils or adenoids are found in the posterior roof of the top pharynx of throat. So the nasopharynx is that region of the throat right behind the nose. Okay. So we have those shown on our models, kind of an orange-brown color. So right up here. So I wasn't there for his surgery. My husband took him. I had his baby sister, and my other son was getting an award at school, so I went to the award ceremony, and then went to the surgery, and Will was already done with surgery and in recovery. And after the surgery, they said, well, does Will sleep with his mouth open? And we said, no. Well, does he snore? And we said, well, we hadn't really noticed. And under anesthesia, his tonsils, his adenoid tonsils were so large, they said, that his nasal air passageway was completely closed off. And so over here, we have a segment and characteristic structures of the tonsils. May I erase the diagram? You guys got all your pictures? Are deep clefts, deep indentations. And this allows for, unfortunately, sometimes trapping of bacteria in those clefts. Because they lie just below the surface, they're only encapsulated on the deep aspect, on the connective tissue side, not the epithelial side. So one, the surface in contact with the the pharynx is going to have epithelium for that area. So in the adenoids, they have a respiratory epithelium. They have pseudostratified columnar. In the tonsils, the palatine tonsils and the lingual, they have the non-cornified stratified squamous that we find in the mouth. So we have an epithelium. We'll do the palatine here because it's a little easier to draw. And then they have these deep tonsillar clefts. The connective tissue enables a little easier removal, so it would be in here as a deep capsule. So you can see why there are no afferent lymphatics, because incoming is going to be via the surface of the mouth or the throat, but we do have efferent lymphatics. So efferent lymphatics are present. We definitely have lymphatic follicles. So I'm just going to draw the circles here. The solid line does not mean that that's a capsule, all right? It's just kind of showing the extent of the lymphocytes. So these would be follicles like any other follicle. There's no cords because there's no medulla. And our epithelium is the site where the integrity might be lost and viruses or other pathogens find their way to enter in. So tonsillar crypt. The epithelium could be either pseudostratified, columnar, if it's an adenoid, the nasopharynx, or non-cornified stratified. I say non-cornified instead of non-keratinized. If they are palatine or lingual. The palatine and the lingual are found on either side of the palate. So if you look in the mirror, in your uvula, the little round structure is hanging down, not round, but tongue-like structure. So here's the back of your mouth, here's your uvula, here's the top of your tongue. There are two arches that are seen, and if you have the tonsils, the palatine tonsils, they're found as a pair within those two arches. Okay. So on this model here, you can see them just right here within the wall of the pharynx. The third type are the lingual tonsils, and they're actually found at the root of the tongue. So if you don't have a very strong gag reflex, you can take your finger and run it across the back of your tongue. And before you touch the top of your epiglottis, you would be on the lingual meaning tongue, lingual tonsils. And we have a rose tongue, and that's a rose tongue. This is almost a rose tongue. I have no idea what animal this is from. It's not a cow because they have really long tongues. But here's the tongue, here's the larynx, and right here would be the pair of lingual tonsils. All right. So if we look on our small larynx model, it also has a tongue. So in the back, here's the surface of the tongue that you can see, and right here would be the lingual tonsils. Back in early 2000s, I had a student tell me that she had had her lingual tonsils removed. And I said, I'd never heard of such a thing. And she said it was the first time her doctor had actually done it, but they were so large that she couldn't swallow. And after that, I had a friend of mine relay, she had a picnic lunch with a family, and their little girl would only eat like applesauce and soup. She wouldn't chew any sandwiches. And with the picnic was a friend who was a doctor, a rheumatologist, studied allergies. And he noticed, she only always eat liquid, and they said, yeah, she won't eat anything solid. And he said, well, take her to see a doctor, and that was her problem. She had such swollen lingual tonsils that she could only swallow liquids. And so having a capsule makes it a little easier to remove tonsils. They have a special kind of spoon-like structure that they can just kind of scoop the tonsils out and cauterize the blood vessels in the connective tissue. This is a much more serious surgery in adults. So when my son had his tonsillar abscess a couple of years ago, he had a sore throat for a week or so. The health center had said it wasn't strep throat, and that was the last they dealt with it. And this was his whole being admitted to the hospital for pulmonary right-sided congestive heart failure kind of thing. When we finally took him into Center General, they took out 15 mils of pus from one of his tonsils. And the surgeon, they had brought in a specialist to do it, and he said he should have his tonsils out. Well, in the adult, it's a 2-week recovery period. And so he was left for the summer to work, and I was just like, okay, if it happens again, you know, you have to be sensitive to your symptoms and not let it go for 2 weeks. And he was in jeopardy of having it so large, it was his palatine tonsil, that it would block his airway. If it happens again, we'll take him out. So that's been 2 years now. And he's always going to get this checked as soon as he has just a little bit of a sore throat to make sure that it doesn't get as bad. And the abscess is because the bacteria were trapped within these crypts, and they're not flushed out very well. And just, it wasn't so much the follicles that were enlarged as it was a surface attack of the bacteria. So no afferents, only a partial capsule. They still have the follicles, all right, but there's no cortex, there's no medulla, so there's no medullary cords or sinuses. Now you're already familiar with the spleen because of our splenic vessels and the portal vein and trunks of the celiac trunk and its branches. So the spleen is on the left side or the right side?
Left side.
The left side. I had to smile. I was looking up something on, I don't know, some site for my daughter, and it was talking about the liver problems and liver pain, and it had a picture. They just pulled out illustrations, and it was a website, and it said liver pain, and it had a guy grimacing with his hands over on the left side of his body. And I was like, that's all we need is people look for liver pain and expect it to be left-sided pain. Choosing the wrong illustration for that. But that would be the spleen. And the spleen has two functions. All right? One function is the storage of red blood cells. And so that's what gives it its dark red appearance, similar to the liver, are the number of red blood cells. And so we have a region of the spleen identified as red pulp. And so this is for red blood cell storage. The structure of the vessels in the blood cells, or the blood vessels in the spleen that have to do with the red pulp, are such that typically our epithelial cells that form the capillaries and the venules are oriented in a circular fashion around the diameter of the blood vessels. In the spleen, they're oriented longitudinally, the length of the blood vessel, and it looks like the staves of a wine barrel. So you think of the long oak planks as being the epithelial cells, and you know how wood dries, gaps appear. So if you've ever used a redwood ice cream maker, when it dries up, gaps appear. So whenever I make ice cream, I have to take our ice cream maker and soak it in the bathtub for a couple of hours to allow the wood to swell up and tighten up those spaces. So with those gaps, red blood cells can easily leave and come back into the blood vessels. Helping that, in the capsule of the spleen, are smooth muscle cells. So there's some trabeculae, it's not well organized, we don't have subcapsular sinuses, but we have a capsule, like all other capsules, is going to be dense, irregular connective tissue. But we have scattered smooth muscle cells. So theoretically, the capsule can contract and increase internal pressure on the spleen and squeeze out red blood cells. Okay. This has only been demonstrated to actually occur in dogs. I've had a hard time finding it as a source of your second wind, say you're out running, but the smooth muscle cells are there. So theoretically, in essence, that could happen. But the spleen does form a reservoir, so whether those extra red blood cells move into the blood vessels because of smooth muscle contraction, or just when there's a demand for higher oxygen transport, that's a source of quick available red blood cells instead of waiting for new ones to be synthesized in the red bone marrow. Okay? The other function of the spleen is filtration of the blood. Passage by or through lymphatic follicles, just like we have in the lymph nodes and the tonsils. Only these lymphatic follicles are wrapped around the blood vessels. So rather than having lymphatic fluid filtering through the follicles, we have the plasma, we have the blood cells filtering. And so this area of white blood cells is known as white pulp.
That's the filtration part.
So there are no afferent lymphatics. We're not filtering lymphatic fluid, we're filtering blood. So the splenic artery comes into the spleen and sends branches which break down into smaller and smaller branches. And around these smaller branches, we find populations of lymphocytes. So I'm going to use this right here as an example. And so rather than a sphere, they actually are a little bit more elongated. Obviously the size of this and the organ is not to scale. And so this is called a periarteriolar lymphatic sheath. Let me write that word out. Peri meaning around, arteriolar, a small arterial, lymphatic sheath. In essence, that's our lymphatic follicle. Okay? It's an accumulation of lymphocytes around an artery. If we look at this in cross-section, what we see, and again, scale is not appropriate here, but we see that blood vessel, either in the center or slightly off-center, and the lymphocytes around it. Because it's a cross-section, it does look like a lymphatic follicle. It's round, but it's really elongated along the length of the blood vessel. And so this content, rather than being called an arterial, is called the central artery. So as blood flows through the branches of the splenic artery and gets to the central artery, it's a little more permeable than other vessels, and the fluid can leak out of these vessels and percolate through and by the lymphocytes and expose any antigens or pathogens that have antigens in the blood to the lymphocytes. So that's why we're filtering blood. So those regions of lymphocytes are identified as white pulp. So here's kind of what I drew on the board. All right, so you'd have the PALs. And then these would be the blood vessels where the red blood cells are leaving to be stored in the spleen or come back into the vessels. Let me take this picture here and just make it a little bit larger. Yeah. So, I'll do it this way. So here you can see that there is a circular structure. This one you can see the blood vessel in it. So when I show it to you for lab, you'll definitely be able to see that blood vessel. And that tells you right away you're looking at the spleen. Okay. A raw spleen cut has areas of this kind of reddish and lighter purple and darker purple area. It's the red pulp and white cut. So somebody who has their spleen removed is not going to die, but they have to take precautions against blood-borne infections. So if they go in to get their teeth cleaned or to have dental work, the dentist needs to know this and prescribe prophylactic antibodies to start taking before they have the surgery, because cleaning teeth can cause the gums to bleed, and there can be an introduction, it shouldn't, but it can, there can be an introduction of bacteria to the blood via the vessels of the mouth, and without the spleen to aid infiltration of that, it can increase their risk for sepsis. So there is a capsule. It's unique because it has smooth muscle. It's the only lymphatic organ that has or structure that has a capsule that has smooth muscle. Remember, it has no afferent lymphatics. That's only the lymph node. And it's the only organ to filter blood. There are efferent lymphatics. So like any organ, there's lymphatic fluid that's going to need to be captured. And so it's going to have efferent lymphatics, but not afferent lymphatics. Okay, the last organ we're going to talk about is the thymus. We've talked about the thymus already. The first week when we did the endocrine system, it's a hormone called thymosin. Remember, its location in children and infants is the heart, the upper part of the heart, and into the superior mediastinum. As you get older, around ages of 12 to 18, those epithelial cells that form the thymus tend to die and replaced by adipose tissue, by adipocytes. They don't turn into adipocytes, but they die and are replaced by adipocytes. We'll talk about more specifics of the thymus on Thursday, because they're involved with the T cells. This is a cat's thymus. The thymus, so all T cells and B cells are produced in the bone marrow, in the red bone marrow. B lymphocytes stay in the bone marrow to mature, hence they're called B lymphocytes. Actually, they get their name because in birds they stay in a structure known as the bursa of Fabricius. But both B and bursa and bone marrow start with B, so we leave that. And the T cells move to the thymus to mature, hence the word, the letter T. Now, as we'll talk about on Thursday, what happens in the thymus is a series of selective activities. And the cells that pass or fail, depending on the test, are gotten rid of, they're triggered to commit cell suicide. All right? That was cell, not self, because obviously suicide is self. So they have what we want, are T cells that are mature, that number one can recognize an antigen. Number two, we don't want it to recognize self-antigens, all right? So if it can't even recognize the molecule that holds onto the antigens, the presentation of antigens, if it can't even recognize that, it's triggered to commit suicide. Anybody know the term for suicide by cells?
Cytokinesis?
Nope.
Lysate?
The second P is silent, so apoptosis. Ptosis by itself is grouping of the islets. I'm not sure how this comes to, but the cells undergo a series of chemical reactions and die. And then the ones that are left, if they react too strongly to antigens in the body, we don't want that to occur. We don't want autoimmune responses. So if they react too strongly, then they have to die as well. So we're left with a population that are sensitive to foreign antigens but not self-antigens. And those populate the body. So all the T cells that you need for the rest of your life, unless you develop a disease that kills off the T cells, like AIDS, are already populating your body by the time you reach 20. And so the thymus then goes into disuse. So the thymus has we looked at this a little bit at the beginning of the semester. It does have a cortex and a medulla, but it doesn't have follicles. The thymus is not a screening process. It's not a filtrating process in the sense of we're trying to filtrate blood or lymphatic fluid. It is a nursery for developing T cells. All right? So the cortex and medulla have nothing to do with the functions of the lymph node. The thymus, it has lobes and smaller lobules that are very angular. So rather than one cortex and one medulla, each of these lobules has light and dark regions. If you're on high enough focus, some of the epithelial cells form these concretions, if you will. They're very distinctive for the thymus. They're called Hassel's corpuscles. You don't need to know the name Hassel's corpuscles, but to recognize them helps you to identify that this is a thymus. And so we'll look at this a little bit, not much more detail, but a little bit more on Thursday, where there's a gradation of where these developing T cells are exposed to what the blood is bringing to the thymus as far as structures that are antigens that are associated in the body. Because T cell, well, I don't want to get to that story. T cells are primarily going to, the T killer cells are primarily going to attack structures with foreign antigens that appear to be synthesized by the cell itself, rather than macrophages breaking down as products via the lysosome and then presenting onto its surface. So for instance, a virus infects a cell. The virus takes over that cell's nucleus and gets it to make new proteins that create new viruses. The cell nucleus just thinks it's making messenger RNA for its own proteins. So because the cell, using ribosomal ER, is synthesizing those new proteins, the cell acts as if it is those cells' proteins and puts pieces of them up on its surface as if it's the cell's own new proteins. Similar with the cancer cell. Mutations of the DNA cause the cancer cell to make proteins that it wouldn't normally make, but it presents them on its surface as if they were its own proteins. A transplanted cell makes its own proteins, but they're different from the proteins. If I get a liver transplant, it's different than the proteins I would have on my own surface. So that's what T killer cells are sensitive to, all right? So the cells produce proteins that are present on most of our cells, whereas B lymphocytes are triggered by the macrophage digesting foreign proteins. They have a different way of presentation. So that process we'll look at on Thursday. What I want to do now is take a break for about, let's go till the maximum quarter of, because I want to come back to and talk about non-specific immune components. But I want you to have some lab time for looking at these different organs. So take a break if you So here's another view. Notice the sharp angles here. So when we were in the endocrine system, some of you may have confused us with islets and Langerhans. We're not dealing with pancreas, this sequence, so you're just trying to differentiate it from spleen and lymph nodes. And it doesn't look like any of those. All right, the lower left is starting to pick up some adipose tissue. So that's what you're seeing, those white areas as it gets older. Here's a lymph node.
Oh, wow.
So it looks a little bit different from the diagram we saw because it can be cut at different angles. But you'll notice that you see a capsule, all right? You see scattered follicles around the outside, not so much in the center. Now, in this particular cut, it doesn't have any afferent or efferent lymphatics. This looks a little bit more like what we just looked at as a lymph node, the medullas. And so here, I could actually ask for lymphatic cords, medullary cords, and medullary sinuses. And here you can see prominent germinal centers. Again, no afferent lymphatics or efferent lymphatics. But you can definitely see a distinctive cortex and medulla. So this one I wouldn't test you on as far as identifying structures because they're hard to see. But here they're relatively clear, right? Here you can see the cortex and the lymphatic follicles. But again, this by itself would be difficult at your level of understanding to identify as a lymph node. So I'd probably show something like this first and then maybe a higher power for the lymph node and then moving into the cortex.
The follicles are the circles.
Right.
The dark circles. And then the lighter color of the follicle is the...
It's where the lymphocytes have been activated, the plasma cells, and we call it a germinal center.
Okay.
Okay? And here's another view. So can you see the cortex and medulla here on this particular side?
Outside the medulla is down, bottom.
Yeah. So all of this is medulla. So the darker area here would be the cords. The lighter area is still cellular, but not as dense. So this would be a medullary sinus. And this would be the cortex with lymphatic follicles, or up here.
And the center that's clear.
That's, I don't know why it's blood vessels, but it's not the spleen, because we don't have sinuses in the spleen.
But it could be considered a blood thing.
Yeah,
The blood
probably a
vessel.
blood vessel.
Okay.
All right, so this is just an individual. It does have a capsule down at the bottom, which is showing you the germinal center.
Is the what's
yeah.
the germinal center again?
The germinal center is activated B cells that have become plasma cells and have more cytoplasm, which doesn't stain as darkly as the nucleus does. So this is just another sort of medullary cords and sinuses. If you see medullary cords and sinuses, those column-like structures, it's a lymph node. Okay? So the long arrow is showing medullary cords and sinuses. So compare those to these in the lower portion and to these. So anytime you see cords and sinuses, it's a lymph node. No other lymphatic structure has medullary cords and sinuses. So what do we have? Well, it says up at the top, tonsil.
Because you can tell by
So you want to look for those crypts. As well as if you can tell there's an epithelium, it has to be a tonsil. Because no other lymphatic structure has a surface epithelium. But the easiest thing is the crypt. The indentations and imagination. So a tonsil again, but again, you've got those deep crypts. So this one is a high power. You can see the epithelium.
This is germinal center.
Because it's a follicle. So it has B cells in the center. So any of these tissues have follicles.
Oh, okay.
So a follicle can be by itself, or it can be in a lymph node, or it can be in a tonsil. And so it can have a germinal center. So here we have the spleen, low power. You can see the red pulp is the red, the purple, and the white pulp is the dark blue. So here is a central artery with the pulp around it. There's red pulp and white pulp. This is probably the most characteristic view of the spleen. So you can see the muscle. What we didn't see in the lymph nodes that had the round circle, you didn't see any smooth muscle on the blood vessel. So here you're seeing a circle of red smooth muscle associated with the follicle. And that red circle of smooth muscle associated with the follicle shows you it's the spleen. That's our central artery. And then this is, you don't have to recognize the histology of the appendix, but this is just another area. Here's the Peyer's patches. Peyer's patches is 15 or more, well, very close together, because you won't probably count 15 all at one time, follicles. And those don't have a capsule, but they're very dense follicles. Okay. So I've got everything out there but the ileum. Now let me go get an ileum with Peyer's patches. But I have spleen and tonsils and thymus and lymph nodes over there on the right.
We get different ones, right?
Okay, she said the germinal center was the activated B cells area, right?
She said the germinal center was the activation of B cells that get converted to plasma.
So we have more space around it.
Okay. Way back here is a palatine. That's what the palatine
This is a lymphatic follicle.
is on the palate.
This is, what she say?
Okay.
I just know that's a part of the lymphatic system. So
What happened? William's tongue? On your tongue? Okay, so that's really cool. I thought they were the tongue because I thought it was the palate, so I'm wrong.
One slide is labeled ileum, that's the pink staining that has the Peyer's patches. The other ones that are labeled Peyer's patches are green stain. Either one will show you the Peyer's patches.
We had last time.
Yeah.
Oh,
yeah, we're supposed
And we're going to look at the specific aspect of defense starting on Thursday, but we have non-specific. So all of our white blood cells, except which ones, function in non-specific.
Lymphocytes?
Lymphocytes, exactly right. So non-specific is the inflammatory response along with other things that we talked about when we looked at skin last semester. And we had the release of chemicals by the neutrophils to draw additional white blood cells to the area, and the diaphoresis, the moving additional white blood cells to the postcapillary venules. I use a slightly different terminology than some textbooks. All right, so let me explain that for you. Because for some textbooks, the second line is still the surface. They call the first line of defense the surface membrane barriers, and the second line of defense, say like the acid in the stomach and so on. My first line of defense is everything that's outside the surface, on the surface or outside the surface. So you're trying to, invade an island, and you get to that, you've got incoming missiles, surface-to-sea missiles, and so all the stuff that you have to fight before you actually get on the island. And then you get on the island, and there's, the mines and all that kind of stuff. You finally get through that, and then you have to actually do hand-to-hand combat with the soldiers. So you're in the second line of defense. You actually made it through the epithelial barrier. So the first line of defense is both mechanical barriers. So the actual junctions of the epithelia, either in the skin, on which is what this is showing, the esophagus, all right, or the pharynx, so non-cornified, stratified squamous, a lot of cell junctions in that epithelia, and unless there's a cut or a tear or a scrape, that has pretty good integrity. So that's what I mean by a mechanical barrier. In the small intestine, it would be the simple columnar epithelia. that would form that mechanical barrier. In addition, we reinforce that mechanical barrier, and here I included as part of the first line, some textbooks make that the second line, but to me it's still the first line. You still have to get through all of this, is the environment. So we have sweat, we have lysis enzymes and antibiotics in our tears and in our saliva. We have the acidity of the stomach. We have digestive enzymes. Okay, so all of this is forming the mucus of the respiratory tract. All of this is forming a barrier, really, before it can even get to the mechanical integrity. So if we have a change in the pH, all right, for instance, my son was on antibiotics for pneumonia, and the antibiotics killed off the bacteria, but allowed the yeast to grow. So that still hadn't passed through the epithelial tissue, but he had a change in the integrity of the chemical barrier in his mouth. So now if we break through that, now we're actually having viruses or pathogens within the loose irregular connective tissue. So now we require an additional cellular defense. So that's the second line of defense. And it's going to be, in our listing here, it's going to be non-specific because our third line of defense is the specific aspect. Okay? So our second line of defense includes a great variety of things that can happen. From phagocytosis, so our macrophage, our neutrophils, our eosinophils are all phagocytic. Right? The macrophage from the monocyte, the neutrophil, the eosinophil. Our lymphocytes can be phagocytic too, the B lymphocyte, but that's under specific defense, so I don't have it listed here. And our basophil is the only cell that's not phagocytic. It releases histamine. So you probably know the process of phagocytosis. We'll look at this again on Thursday as it involves antigen presentation. But this is non-specific. It doesn't require receptor marker recognition and interaction before any of these cells will undergo phagocytosis. And here you can see pseudopods coming out in ingestion of bacteria. It doesn't matter which bacteria, it's going to be phagocytosed. Involved with this, we also have natural killer cells, or NK cells. These are actually a type of a T cell, but they don't have to recognize any particular receptor, all right? They recognize generalized components. They still will result in rupture of the attacked cell and lysis, but they do so, the recognition process is not there that's required by our typical T killer cell. This has nothing to do with movie plots or anything like that, okay? But it's a non-specific T cell, or derived from T cells. Fever is a non-specific response. So the body has a set temperature in response to viral toxins or to bacteria. They release chemicals that are identified as pyrogens, right? Which means causing an increase in temperature. And the body uses that for decreasing the effectiveness of bacteria and viruses, their enzymes. And in fact, if you're taking care of a child and they have a temperature up to but not over 100 degrees, you don't want to give them a bunch of Tylenol or ibuprofen and bring that temperature down to normal, because that is actually part of our defense system. Now, if it goes over 100, all right, then that temperature can be damaging to the body. And if it's really high, of course, it can be damaging to brain tissue and so on, and that is affected by dehydration. So you want to make sure their fever isn't caused by dehydration and lack of ability to get rid of heat, so keep them hydrated, but allow the temperature to at least go up to 100. So it affects the bacterial activity, affects the metabolic rate, increases the metabolic rate, and allows the body to be more active in keeping the body not toxic, but a lethal environment for bacteria. And then the inflammatory response, which we've covered previously. So that's diagrammed over here. We have an infection, a break in the mechanical integrity. We have our neutrophils, which are the highest population of our white blood cells, are going to start doing phagocytosis. They will release chemicals, all right, that form a gradient, and that will cause diapedesis of additional white blood cells that will follow the concentration gradient of those chemicals to that area. In addition to white blood cells, we have mast cells and basophils that release histamine. Histamine increases the permeability, increases the blood flow, so we have redness and swelling. That can result in pain, but it is bringing in more blood and more white blood cells to the area. Right? So you may have heard that it's a good idea to do alternate hot and cold soaks for an infected area. My daughter, when she was about 8, went off to camp, and Saturday afternoon they were climbing around a waterfall, and she did it barefoot and stepped on something and got a bad cut on her foot. When she came back, it was all infected. And I was like, did your counselor see this? And she said, yeah, but she didn't send me, did she send you to the health center? And she said, no. So I was like, okay, well, here's what we're going to do about it. So I just did about 3 or 4 days of alternate hot and cold soaks, which bring an increased circulation to the area, and then the cold drives it away, and then hot again brings it back. So you're increasing the cycling of fresh phagocytic cells to the area, right? Because obviously they're going to fight and get overcome, and you need new ones coming in, new cells coming in. So on the next page, so the inflammatory response, if you want to go into more detail than that, you can go back to the skin chapter. It talks about all the chemicals that are released, the bradykinins, and so on. So here are some of those chemicals. Well, I'm not a good speller, at least I've been synthetic today. He's been up here for a while. One of the things that you will have on your exam is a matching of cells to their secretions. So plasma cells obviously are going to release antibodies. T lymphocytes, when we talk about their function on Thursday, release chemicals, a variety, one of which is known as perforin, as do natural K cells. And so basophils and mast cells are going to make histamine. All right, bradykinins, prostaglandins can be released by endothelial cells, and obviously cytokines are just chemicals, there are a variety of chemicals released by our white blood cells that attract additional white blood cells. So as you go through, especially on Thursday and Friday, we'll add some additional components to these, but matching up the cell to the variety of chemicals that are released. Then we have another group, several different types of antimicrobial proteins. Interferons are one. When interferons were first discovered, I don't know if it was late 60s or early 70s, I remember them in the 70s, there was this big buzz about we found the cure to cancer. Because viruses, when they, many, not all, but many cancers, such as leukemias, are caused by viruses. And interferons are a type of molecule that when a virus infects one cell, it causes that cell to synthesize a type of protein called interferon. It doesn't help the cell that's infected. But like a paracrine or an autocrine, it goes to the next cell and causes that cell to then synthesize proteins that block viral activity, either infection or reproduction. So it goes out, and the cells that have the interferon effect are protected. It's altruistic. So it's not going to save this cell's life, but it can increase the probability that the surrounding cells can prevent the infection by the virus. So it was thought that interferon could be used as an anti-chemical virus and keep viruses and the cancers from spreading to other cells. It hasn't quite developed that way. So this functions more like the acyclovir that you might take, or the Tamiflu. So if you get the flu, you go and take this. When I got shingles, I took a drug that kind of blocked the virus from multiplying and spreading and limited the time spans that the infection and symptoms lasted. So it's non-specific for any particular virus. It is specific to viruses, but non-specific to any particular virus. So that's a type of antimicrobial protein. So, in your table of cells that make things, this would be associated with just any virus-infected cell. So it doesn't have to be a specific type of cell, just any virus-infected cell is going to release interferon. All right, complement is a complicated series, so let me limit it. If you've had microbiology, you know this way more detail than I'm going to go into it. So let me emphasize the components that I want you to understand. It's a series of 20 or more proteins that are similar to clotting factors in that they are present in the blood. They need a trigger to cause them to be activated. They are numbered, and the number in which they're activated has nothing to do, it's not sequential. Similar to our clotting factors not being sequential. So while I'm not going to ask you to be able to reproduce this sequence, I'm going to go through it with you because the 3 results of its activation I do want you to know. All right? So first of all, complement proteins are inactive molecules in the blood that can become triggered to go through this pathway by 2 different stimuli, or 2 different events. Remember with blood coagulation, we had intrinsic and extrinsic pathways? All right, so 2 different triggering events. This is similar to that, 2 different triggering events. So the classical pathway involves the exposure of the complement proteins to antibodies. That does not mean it's specific. Remember, as I have drawn antibodies, I have drawn a Y structure. It is this part right here that the complement is sensitive to. So if we have a bacteria that is coated with antibodies, right, then that will trigger complement proteins interacting with that region of the antibody, which is nonspecific. Right? It will use it when we talk on Friday about antibodies. It will help us to identify whether it's an antibody G or an antibody E or an antibody D, but it's not specific to recognizing an antigen. So when the complement interacts with that part of an antibody, it can trigger the interaction between a series of complements. But because it's the non-specific part of the antibody, this is still non-specific. Does that make sense? If it had to react, if it only reacted with a certain antibody at this end, that would make it specific. But because it's reacting with what's called the constant region, it's non-specific. So interacts or activated by contact with the constant region. Called the FC, or constant fragment, of antibodies. Right? And the alternate pathway, it is direct contact with bacterial coat sugars. or maybe I should say starches, because they're polysaccharides. So here, the antibody itself may be interacting with the polysaccharides or glycoproteins. Here, a naked bacteria will interact with the complement and trigger the pathway. Okay, so that's the difference between classical and alternate. But let me emphasize again that the antibody interaction is nonspecific. It's similar to an allergic response that we'll talk about later. So what happens is the different series of complement start. So here we have C3. And when it interacts with the antibody, all right, or with the protein coat, it splits into two parts. And again, you don't have to reproduce this. You don't have to know it's C3 versus C6. Okay? So C3 is going to bind to the surface of bacteria and coat its surface with C3b. That's one event that can occur as a result of complement activation. Coating the surface with anything is called opsonization. All right, so this was opsonization by the antibodies. This is opsonization by C3b. And opsonization just makes it, it's kind of like waving a red flag to a macrophage or a neutrophil. It makes it more likely that that opsonized cell is going to be phagocytosed. Okay. So C5 then becomes active by its interaction with CB, and it splits to form two segments. And so the other activity that can occur, so this is one thing that can occur as a result of complement. Okay. The other thing that can occur as a result of complement is the activation of mast cells. And if you recall mast cells from Bio 430, they release histamine just like basophils do. So this is the second event that can be triggered by complement activation. And mast cells themselves are not going to kill anything, but they increase permeability, they increase the inflammatory response, they bring more neutrophils and more everything else, and increase the likelihood that phagocytosis occurs. And then what complement is best known for is we take additional complement molecules, C6, C7, C8, and C9, and a donut-like structure is formed that is inserted into the plasma membrane of a cell. This is known as the membrane attack complex. So MAC. What some people call the MAC attack. And that creates a permeability in the cell, so it's inserted into the bacteria primarily, but it can be in other cells. And that results in lysis of the cell, rupture as it creates this opening. So this would be the third mechanism by which complement works. Okay? So again, you don't have to know these individual sequences. You don't have to know it's C3 or 5A or whatever. But recognize the different triggers, the two different triggers, and the three activities that occur as a result of complement activation. Okay? If I were to give you this diagram, recognize it as complement. Okay, without having to identify which one is activated first or which one is activated last. And it's part of the non-specific factor. It is also another example of positive feedback. Okay? In the same manner as our coagulation clotting factor activation with positive feedback. So here you have the result of the MAC-attack. Okay. So we will stop there and pick up the third line of beacons on Thursday.
Okay, real quick, so what is oxygenation?
Oxidation is when the